All right, so we'll get into chapter 16, which is going to begin our infectious disease unit, and it begins with the respiratory system infections. All right, so if you haven't seen yet the video with the assignment instructions for the coronavirus assignment and the 1918 flu pandemic assignment, make sure you check out that video. You'll definitely want to watch that so you have the instructions and all the information you need to know to complete that assignment. Okay, the coronavirus assignment is for a lab grade, and the 1918 virus assignment is for an assignment grade. And then also don't forget chapter 16 on mastering. Okay, so check out that other video. It'll give you some important background information. So chapter 16 involves the respiratory system. And as you probably know, especially since many of you have taken anatomy physiology too, you know that the function of the respiratory system is to bring in oxygen and remove carbon dioxide from the body. What you may not have realized, though, is that the respiratory system is the most common portal of pathogen entry in the body. So breathing in or bringing something in from the respiratory system brings in a lot of stuff, okay? And where that pathogen ends up or how devastating or how mild the infection is depends on that pathogen. Some pathogens affect the upper respiratory system and others do the lower respiratory system, and some do in fact both upper and lower. So which do you think is worse, attacking the upper respiratory system or attacking the lower? Think about that for a second while I define upper and lower. Okay, so we have a division there, and the upper respiratory system is basically everything from the larynx or above the larynx. So we have the sinuses, the nasal cavity, the mouth as well, and the throat or the pharynx. Okay, the pharynx is a fancy name for throat. The epiglottis is a little flap here that helps protect your airway when you swallow. Okay, so when you eat or drink something, this epiglottis basically comes down and covers over the trachea so that your food can pass down through the esophagus and not go into your windpipe. Okay, now in the lower respiratory tract, that's going to be your voice box and everything else down. So your windpipe is called the trachea, and then it's going to branch into what we call the bronchial tree. The large diameter tubes, okay, because these are tubes bringing air in, the large tubes here are called bronchi for plural, or this is the left bronchus or the right bronchus. And then they branch off, just like a tree branches off into smaller and smaller tubes, and the smallest ones are called bronchioles, and it ends with the little air sacs called the alveoli. Now, some people like to think of the lungs like a balloon, okay, which the lungs do inflate, but the lungs are not just like a hollow cavity. They are filled with tiny microscopic air sacs, okay? So the lungs do expand like a balloon, and they deflate like a balloon. But the air goes into these tiny little air sacs called alveoli, and that's where the gases are exchanged with the blood. So what do you think? Which is more detrimental to the body, an upper or lower respiratory infection? If you said lower, that's correct, because down here, if you impede oxygen exchange, that can be life-threatening, right? Our bodies need to have a constant supply of oxygen so we can undergo cellular respiration to produce ATP energy for our cells, okay? So lower respiratory infections can be life-threatening, much, much more so than an upper respiratory infection, okay? In our respiratory tract, especially like the sinuses and the trachea, and to some degree the bronchi, they have little cilia on each cell that lines those tubes or passageways. Also, we have what are called goblet cells. Those cells produce mucus. So the mucus will trap bacteria and foreign substances, and then the cilia will sweep the mucus with all of its gunk stuck inside of it toward the mouth and nose. So in the sinuses, it's going to sweep that stuff down so you can blow it out or cough it out or whatever. In the trachea, down here in the lungs, it's going to sweep that stuff up so it can be coughed or spit out. Now, if a person has inflammation of the sinuses, remember itis means inflammation of, you get a blockage here because this passageway is blocked. So this mucus starts to build up, or you could get blockage down here. If you've ever had a sinus infection, you can definitely tell right where your sinuses are, right? You get pressure in your sinuses. That inflammation causes a lot of mucus buildup, and it causes a lot of pressure. Okay, so once that mucus builds up, it's a great breeding ground for bacteria, and so that can cause an infection. However, the sinuses can become inflamed because of viruses or allergens as well. A-L-L-E-R. Okay, so bacteria, viruses, or allergens can cause swelling of the sinuses. And so the most common are the viruses or allergens. And so, excuse me, a lot of times doctors will make you wait a while before they just give you antibiotics for your sinus infection, because somewhere between 15 and 20% of all outpatient antibiotics are given to people with sinus infections. Okay, so inpatients, a little bit of different demographics. Like if you're looking at people in the hospital, that's kind of separate. But for all the people that are not in the hospital, about a fifth of them are getting antibiotics because of a sinus infection. So we really want to make sure that we're not giving antibiotics when it's not absolutely necessary. A couple other terms: pharyngitis means sore throat. Epiglottitis is basically swelling and inflammation of the epiglottis. Okay, and that can be kind of life-threatening because if it becomes too inflamed, it can block your airway and prevent you from breathing. Another term that wasn't on that slide is called the mucociliary escalator. And that is basically this process of the cilia taking the mucus and sweeping it up so it can be coughed out. Now, if a patient is a smoker, they can receive damage to their cilia. And so when the cilia are damaged, they cannot extract the mucus and the debris, and so they are at a higher risk for lung infections. Some signs and symptoms of respiratory infections could be either upper or lower. First of all would be coughing. That's a good sign that you have something respiratory going on. Stridor is also known as wheezing, we said. Dyspnea, shortness of breath, fatigue, sneezing, sore throat, and also fever. Okay, so those are some of the ways that a respiratory system infection could be presented. A couple other terms. These are all pretty easy. Add a structure with and put itis on the end of it means inflammation of it. So laryngitis, if you've ever had that, you know, you lose your voice, you can't hardly talk, you might have to whisper. Tracheitis, inflammation of the trachea. Bronchitis, get inflammation of those bronchi. Maybe some of you have had that before. Bronchiolitis is inflammation of those tiny little bronchioles, those tiny little tubes, and you see that a lot of times with asthma. Whoops. ASTHMA. Croup is another term that you might have heard of a lot, especially with young children. Croup is basically inflammation of the voice box all the way down to the bronchioles, that whole system. And the kid or the person would have a barking cough and some wheezing that would go along with that. Stridor we defined, and pneumonia is the last one that I want to define because we've talked about dyspnea. Pneumonia is basically inflammation of those alveoli, those little air sacs that occur. And we all know that pneumonia can be very serious because if we block air exchange or we reduce air exchange, that can cause some big, big problems for the body. Okay, we'll talk a little bit about pneumonia before we end, but we're going to start out talking about viral respiratory diseases. Now, your book talks about a lot of different diseases, and we could spend probably 3 weeks on this whole chapter, but we have a day. Okay, plus I wanted to show you guys some information and have you go through the 1918 flu and also the coronavirus. So we're not going to cover most of these diseases. I would highly recommend, though, if you are interested in a disease, maybe you or a friend or a child or someone you know has suffered with a particular disease recently, or maybe you just want to learn more about one, I would go through and learn and read up about those diseases, especially if you're going into healthcare, making those real world connections to people and what happened to them as they were going through that particular illness and why they had this symptom or why they didn't have that symptom. Just really thinking it through and applying some of this information to people that or even yourself can be very, very beneficial. So I would just really encourage you, just for your own, information, to go through and read some of these. My son, we've talked about him a little bit. He used to have a lot of respiratory issues. I used to go over RSV in class just because it was something that my son went through and caused some pretty severe issues for him. And so, find 1 or 2 extra ones that maybe really stick out to you and just learn about it just for your own information. I think that will help. Okay. One of the viruses that we're not going to talk about is the cold virus. And I just wanted to give you a couple just tidbits about the colds. Colds are caused by over 200 different viruses. Okay, so that's why we don't ever have a cure for the common cold, because it has over 200 different pathogens that basically can cause those signs and symptoms. Over 2/3 of the cold viruses are caused by rhinoviruses or coronaviruses. And you're like, wait, I thought this was just discovered. No. Coronaviruses have been around forever, basically. COVID-19 is a new novel virus that just evolved within the last several months. There's some debate about when it actually started appearing in humans. Could have been earlier than in December when it was previously thought. That I don't know yet. I don't think there's a definitive answer, but this is a novel virus. We see coronaviruses in cattle. We see them in producing colds. We see them producing SARS and MERS. This is just a new strain of that virus. Okay, so I wanted to point that out, that there are a lot of coronaviruses that just cause colds, and then there's this one, which colds are upper respiratory. Okay, this particular one attacks the lungs and is lower respiratory. So that's what makes this one more severe than the regular coronavirus that would just cause a cold. Okay. All right, so let's jump into influenza. okay, or the flu. Now, one of my biggest pet peeves is, and I think I've mentioned this to you before, this influenza is not the stomach flu. That is called gastro, G-A-S-T-R-O, enteritis, E-N-T-E-R-I-T-I-S. Okay, that's where you're vomiting and having diarrhea. Now, once in a while, people with influenza will vomit, okay, and very rarely can have diarrhea, okay? Influenza that you get the flu shot for is a respiratory disease. It causes fever, it causes coughing, perhaps a runny nose, those types of things. Okay, so if you get the flu shot, I've had friends, I just want to like bang my head on the wall. I've had friends say, I got the flu shot and now I have the diarrhea. I have the flu. I'm like, no, you don't. You have the stomach flu, you have gastroenteritis, you have, you know, it's two completely different things. Okay, so please always remember that. If you hear of someone getting the flu shot and they get the stomach flu, please just inform them kindly that it's two completely different things. Okay, so influenza symptoms and signs kind of resemble a cold, only they're more severe, and they also have come with a higher fever, and it's also more prolonged. The fever is more prolonged. Okay, so the influenza virus typically results in a more severe form of like what you would normally get with a cold. You're more run down, you're more achy, those types of things. Okay. Now, most strains of influenza bind to ciliated cells of the upper respiratory tract. So in the nasal cavity and the sinus cavity and stuff, but some can directly affect the lungs, as in the 1918 or the Spanish flu. Okay, and that's one of the reasons that particular flu strain was so deadly. And you can learn more about that in the video. You'll learn a lot more about that particular flu virus. Let's see, one other thing that I wanted to point out, and I'm going to put it here because we have more room. Influenza is spread, as you probably already know, through respiratory droplets. So sneezing or coughing on someone, or even just breathing on someone or talking, has a potential to spread the flu. Personal contact, or we call that direct contact. Okay, kissing, those types of things, and also fomites. Do you guys remember that term? Fomites are objects like cups or doorknobs, or basically inanimate objects that can transmit viruses or any other type of pathogen. So those are the transmission ways that the influenza virus is spread person to person. And for most people, you feel run down, you get kind of yucky. After a week or so, you start to recover. But for those with a compromised immune system, or the very young or very old, or even sometimes young, healthy people, complications can arise. And complications could include secondary bacterial infections, because the body is so much so trying to combat the virus that your immune system's weakened because it's focusing so much on influenza that bacteria can sneak in. Plus, the virus is damaging those cells, those ciliated cells that it's attacking. And so it gives a great opportunity for bacteria to come in and cause a secondary infection. A lot of times that secondary infection will appear as pneumonia, and people that die from influenza usually end up dying from pneumonia. Okay. And again, we talked about those with pre-existing conditions or weakened immune systems. Okay. So influenza is second most common viral respiratory illness. Colds are the most common. And we've talked a little bit about before how influenza virus, it's an RNA virus, and it can mutate basically from season to season and actually within the season as well. And so the severity of the disease year to year is going to really depend on the dominant strain that's circulating. Okay, so in 1986 and 1987, that was a pretty mild season where they only saw in the US 3,000 deaths. Okay, 2012, 2013 was a little bit more severe, as you can tell there. This is from the January of 2013, this particular map showing the severity, or I should say activity levels by state for the month of January in 2013. Okay. Yeah, I'll bring that up here in just a little bit. So again, it's really kind of, because of those mutations, it's really hard to predict what a flu season is going to be like, because it might start out very mild, and it's been predicted to be pretty mild, and then the virus mutates and takes off in a whole different direction. You know, and as we can tell with this coronavirus thing, you know, epidemiologists are a lot like meteorologists. You know, the weather can be sort of predictable, but then it can be unpredictable as well. It's the same thing with these diseases and these pathogens. You know, we can do our best to kind of guess to see where it's at, but at the end of the day, we don't really have control over the weather or over whether these viruses mutate or change and evolve or not. But there's 3 types of viruses, influenza virus. Actually, there's more, but these are the main ones. Type A and type B are the 2 most prevalent. And then there's type C, which is a little more rare. Type B would be more so that we would see in epidemic outbreaks. And let's see. I think we've talked about this before too when we're talking about viruses, are those glycoprotein spikes on the surface of the virus. Influenza is an enveloped virus, and if you remember, it steals the cell membrane, that phospholipid bilayer, from the host cell. And so on the outside of that phospholipid bilayer, and then its RNA is inside of the capsid, they have spikes. And there are 2 forms of spikes. There's the H spike and the N spike. And H is hemagglutinin and neuraminidase. And hemagglutinin, or the H, allows for attachment and invasion of target cells. So if we're talking about feline influenza viruses for cats, its H spike will identify cat cells. Our influenza viruses will identify human cells. If that makes sense. Human respiratory cell, upper respiratory cells. The N spike is basically a particle or a piece of the virus that helps it escape once it's been produced inside of the host cell. So you may have heard of like H1N1 and H5N1 and different letter and number combinations. That's based on what number of the hemagglutinin and neuraminidase protein spikes that particular type of virus has. Okay, so that those spikes are what we use to name the viruses within a type A. There are 18 types of H's and 10 types of N's that are possible that we know of, and so that gives us about 170 different influenza A subtypes. The 3 main ones that are affecting humans: H1N1, which is the swine flu, like we saw in 2009, and then H2N2 and H3N2 are the main ones that we are seeing. Okay, so we mentioned H1N1 is the swine flu. The avian or bird flu ones are the H5 and H7 strains. So H5N1 and H7N9 are found in birds. And why that is important, okay? Pigs and birds carry strains of influenza that are capable of switching over and infecting humans. And I'll talk about how that happens in just a second. Getting new strains of viruses are not very common because the RNA genome has a lot of mutations that can happen. It doesn't have as many protective measures as organisms with a DNA genome, and that can cause a lot of mutations rather quickly. And they're able to genetically mix and match pieces of the RNA. Okay, and we did talk about this during the viral chapter, and I may have even assigned the video before, shown it to you, but I want you to watch it again. The antigenic drift and shift video, I want you to check out. Okay, that's one that's required. If you want to stop the video and watch that other one right now, that might be a good time to do that, to kind of review, but make sure you watch that antigenic drift and shift video. And just kind of remind yourself of what can happen. Antigenic drift usually results in more mild changes, but it does result in some random mutations that can change minor aspects of the H and the N spikes. And it helps it to be able to evade our immune system, because our immune system is used to some of these other spikes and now it's changed. Okay, that's why we get a new flu vaccine every season. Antigenic shift is when we can see pandemics, and that's some major changes, and your video will show you exactly how that happens. But we can take, say, H5N1 strain subtype of this particular type of influenza, and birds and pigs have the ability, those flu viruses have the ability to switch over into humans as well. And a lot of times we see that with antigenic shift. And antigenic shift is what caused the 1918 flu pandemic. And it was also called the Spanish flu. Again, your video that you're going to watch is really, really helpful to understanding what happened and maybe a little bit about how it was spread and so forth. But basically what they believe is that either in hogs or in some sort of bird in the state of Kansas, this virus went through antigenic shift and became able to infect the human population, and it was able to be spread person to person. So the video will help you with that. In Spain, 8 million people died in a matter of 30 days. Okay, so this was a very pathogenic, very deadly virus. The other thing that was unique about this Spanish flu is that young, healthy adults were the ones with the highest mortality rate. Usually we think of the very young and the very old that are going to succumb to influenza, but here it was the young people, and I've heard, or younger adults, and I've heard various explanations on perhaps why that was, and we don't know 100% for sure, but as the video will show you as well, basically what happens is the immune system kind of overreacts, and the lungs can fill with fluid and then cause pneumonia and death. Another reason perhaps because they have a very aggressive, high functioning immune system, would basically overcompensate and then cause the pneumonia. The other thing that I've heard as well is that perhaps the older generation had been exposed in the past to a similar influenza virus and built up an immunity toward, somewhat of an immunity toward that, more so than the younger people. But we're not really sure 100% why the healthy young adults were more affected than the older adults or young children. Let's see, flu vaccine, really good way to prevent. This goes through some myths about the flu vaccine. I'll let you read through that. And I'll let you read through this as well as far as the transmission and so forth. There's some rapid tests. Maybe if you've ever been sick and you've gone in for a flu test, ugh, yuck. What they do is they take a swab and they poke it out the back of your head. No, I'm just kidding. They go in through the nasal cavity and swab basically the back of the nasal cavity. And there is a quick test, sort of like a pregnancy test, kind of like a 5-10 minute test that can tell you whether or not you have antigens for the influenza. Give some signs and symptoms. Here's a good place just to kind of review influenza. Okay, so don't forget to watch the antigenic drift and shift video, and then also the 1918 flu pandemic, and fill out the worksheet for that. So that's the only viral respiratory disease I'm going to talk about. We're going to switch gears and look at some of the bacterial respiratory diseases, and we're, again, just kind of a very quick survey. Pretty much all of us have probably had strep throat at one time or another, and that's caused by Streptococcus pyogenes. Let's see. We know that they're gram-positive cocci, circles that grow in chains, because based on their name, strepto means chain, cocci means spheres. Okay, they can cause all kinds of different diseases. Endocarditis, which is basically inflammation of the lining of the heart, strep throat, meningitis, pneumonia, skin problems, sepsis, cavities, all kinds of different things. Strep throat is caused by group A strep. Group B strep we see in problems in pregnant women. Let's see. Excuse me. Transmission of strep throat in the respiratory droplets. Some people can be asymptomatic carriers, and a lot of times you see it in winter and early spring. However, my son with the respiratory issues did get strep throat in the middle of July once. So it is possible to get it year round, but that's mostly when you see it. Signs and symptoms, inflammation of the pharynx. You also have exudate, or basically pus pockets that you'll see. You can see it's very inflamed and red, a low-grade fever, swollen lymph nodes in the throat. And a lot of times you will not have a cough, but could have it. Complications from strep throat could be ear infection, sinus infection, or pneumonia. Again, there's rapid tests here. I know my kid's pediatrician, the rapid tests, I believe, are about 90% effective. And so they'll always swab with 2 swabs. One goes to the throat. One will go to the rapid test. The other one will go to the lab and be cultured, just to make sure that there's not a false negative. Because strep throat, streptococcus infections are very serious, and they don't want to miss 10% of them because the test isn't working. And actually my daughter had a false negative once, and they called back after 48 hours and said, oh, yep, this test was negative, but she actually does have strep throat and she needs to have antibiotics even though she feels better. And those antibiotics are going to be usually penicillin drugs, like the pink stuff, amoxicillin. Or if you're allergic, you can take macrolides. And I'm going to talk about those complications here in just a second. Prevention of strep throat, wash your hands. That's basically our mantra when it comes to disease prevention, as you are all probably very well aware of with the whole pandemic going on. Wash your hands often. We did a great lab in class, right, to make sure that you know how you're washing your hands and making sure you're getting them clean. So it's important for flu, strep throat, coronavirus, digestive, stomach flu type things later on in the year. Very important to wash your hands and avoid contact with infected patients. If your kid has strep throat, don't be sharing a cup with them, or let them cough on you and things like that. So here's the complications. Okay, so if you have strep throat that goes undiagnosed, okay, some strep throat can turn into, about 10% of untreated strep throat can turn into scarlet fever, okay? Now, the cause of scarlet fever is strep pyogenes that has been lysogenized, or basically infected with a virus. So you're infected by bacteria that's been in them themselves, been infected by a virus. Those viruses cause the bacteria to produce a toxin. So remember, viruses can affect our genomes, and it can affect bacterial genomes as well. And so those that have been infected, those strep pyogenes that have been infected with the virus, now have the ability to produce this toxin. Erythro means red producing toxin, and scarlet fever means red. So it gives you this chest to strawberry red tongue, this chest rash, and those are some of the symptoms of scarlet fever. So it'll start with a face and neck rash and works down the body. It's caused by the toxin. And so forth. So that's strep pyogenes that's been infected with a virus. There's another complication of strep pyogenes, and that is rheumatic fever, okay? Rheumatic fever is basically an autoimmune reaction where antibodies, remember our B cells, the humoral immune system, our antibodies are produced against strep pyogenes, but the antibodies sometimes can cross-react, so we have the same triangle shape there, with our own healthy cells, and that can cause rheumatic fever. Progresses from untreated strep throat, so that's why we needed to have our daughter on antibiotics, because even though her throat felt better, the bacteria still could have been attacking her body. So through that antibiotic autoimmune reaction. So those antibodies from the host can cause inflammation of the joint, the nervous system, the heart valves, and cause endocarditis, which is inflammation of the lining of the heart. Okay, next disease that I wanted to cover, and there's just a couple of them that I'm going to cover, is pertussis, or whooping cough. It's caused by a gram-negative bacteria called Bordetella pertussis. Used to be a childhood disease, and now we're seeing it increase in adults and adolescents or teenagers. And pertussis has 3 stages, okay? It goes through a progression of 3 different stages. The first stage is called the catarrhal stage. And that's where you just basically have like cold-like symptoms. There's no sore throat, you don't have a fever, you just kind of have a cough and a runny nose, just like a cold. And that may last 1 to 2 weeks. Okay, then after that 1 to 2 week period, the person would go into the next stage, which is the paroxysmal stage. And that's where you get the characteristic whooping cough type of symptoms. Those are called paroxysms, where you have this very loud barking cough. And if you've ever heard it, it is very, very noteworthy. You can definitely identify that as whooping cough. And what causes that terrible cough is basically a result of toxins produced by pertussis, the Bordetella pertussis bacteria, that's causing inflammation of the respiratory tract. So at this stage, a lot of times antibiotics don't really do anything because it's the toxins that have been already released and causing problems. But this stage can last a month or longer. And the severe, terrible coughing fits or paroxysms that are produced can lead to vomiting. They cough so bad that they vomit. People have fractured ribs and lose bladder control. And people can also bleed from the eyes and the brain just because of the pressure from the continuous coughing. Very, very severe coughing. And then this should say third phase is the convalescent phase, where the coughing starts to die off, and that can last for another 4 weeks. Pertussis is a vaccine preventable disease. And so here shows incidence by age over the years. And so young children have always been the highest group, but we have seen some rises in older children and some adults. The pertussis vaccine comes in the DTaP, so diphtheria, which is also a respiratory disease, tetanus, and that stands for acellular pertussis. And each one of these produces toxins. That's why they're together in the vaccine. Diphtheria toxin, tetanus toxin, and pertussis toxin is what causes each of those disease. And so just like tetanus, pertussis immunity doesn't last very long. So every 10 years or so, you should get that vaccination again, especially if a woman is pregnant, if you work at a daycare or you work with young children, you're a healthcare provider, or if you're a parent or grandparent that is around young children, PARENT. Terrible handwriting, I apologize. Okay, so here's a good review of whooping cough. We'll let you look through that. And let's see, tuberculosis is another one that I want to talk about, because we have talked a lot about Mycobacterium tuberculosis this semester. We first saw them when we were looking at cell walls. And remember, these guys are acid-fast, gram-positive rods or bacilli. The acid-fast bacteria, remember, they have that waxy mycolic acid. Okay, so, and we also, because of that, we have to do that acid-fast staining technique as opposed to gram stain to identify them. Okay, so people with active tuberculosis can transfer the bacteria onto others. We'll talk about active versus inactive here in just a moment, but worldwide, tuberculosis is the 4th leading cause of death in terms of infectious diseases. Historically, if you watch old Western shows or historical shows, you may have heard the word consumption. Okay, maybe one of the characters in the movie or a book or whatever had consumption. That's what they used to call tuberculosis. It's prevalent in some areas of the world, not super prevalent in the US, but it's prevalent in some other areas of the world, and is also the leading cause of death for people with HIV/AIDS. Signs and symptoms. So most infected people develop an asymptomatic latent infection where they're not contagious. And then they progress into, not all, but many progress into the active stage. And the active stage signs and symptoms would be bloody sputum, spitting up blood, fever, night sweats, fatigue, and weight loss. Okay, so what happens with the disease? It kind of goes through a progression as well. You inhale the M. tuberculosis bacteria. Macrophages, which are phagocytes, would find those bacteria in the lungs and engulf them. The thing is, though, these bacteria thrive and live and reproduce inside of those macrophages, inside of those phagocytes. Okay, so then is when you start to enter the latent stage, and you produce what's called a granuloma or tubercle. And there, basically these infected macrophages and lots of other types of cells involved in the immune system and in the lungs wall off and form these little nodules in the lungs, and they can be detected by an X-ray or a CT scan. Then in active tuberculosis, this tubercle, this granuloma, will burst open. It kind of liquefies and bursts open. And then now when they breathe out, they can transmit the tuberculosis to another individual. There is a vaccine for tuberculosis. It's not routinely given to people in the US, but if you have like HIV or live in other countries, or if you're traveling to an endemic area, you may need to get the vaccine. Typically people in the US, and if you're going into healthcare, you may have already been or will be screened for tuberculosis with a tuberculin skin test. And with that skin test, they basically inject tuberculin proteins, or proteins from the bacteria, into your skin, and you'll have a type 4 delayed immune hypersensitivity response if you have been exposed to the tuberculosis bacteria or have had a vaccine. So if this is a delayed response, so you'll have to go back in 48 to 72 hours, and they'll look for an induration or a hard red area. And most people will not have a reaction, okay, if you've not been exposed to that. But there's basically, based on the size of it, they can determine whether or not you are positive for tuberculosis exposure. Okay, so there's some different criteria there. Let's see. So the skin test doesn't determine between active and latent infection. If you've been vaccinated, you could have a false positive. If you have been vaccinated, you should be tested with molecular assays, basically. If you have a history of tuberculosis, to determine whether it's active or latent, you would have an X-ray or a CT scan to look for those nodules, those tubercules in the lungs. Now, one other thing that we learned about tuberculosis is that there is a lot of drug resistance to antibiotics by tuberculosis. Rifampin and isoniazid are two antibiotics that are commonly used to treat acid-fast bacteria like tuberculosis. These MDR strains are resistant to that, though. It's common in Russia, India, and China, and other places in the world, but those are where it's most common. And then extensively resistant to tuberculosis strains, or XDRs, are resistant to drugs that are used after this. So they're basically resistant to these drugs and others. It's pretty rare right now, but as microbes become more and more resistant to antibiotics, I could see that definitely increasing. Active TB caused by MDR or XDR TB, so the resistant types of tuberculosis, are treated for up to 2 years. Remember, those acid-fast bacteria reproduce very slowly because of that acid deposition in the cell wall. So drug uptake is a lot slower, so it takes longer. The drugs are expensive and they have a lot more side effects. There's almost 500,000 cases in 2015 of MDR TB, and there's about a 52% chance of curing MDR TB, even with those expensive long those 2-year periods that you get the antibiotics for, and a 26% chance of curing XDR TB. So those are not good odds for those that develop those types of infections with the resistant bacteria. Okay. There's a 4 to 6 week incubation period. I'm not going to read through all of this, but that would be something good for you to read through as you are studying for this chapter. The last disease that I'm going to talk about just quickly is pneumonia. Okay, remember, pneumonia is inflammation of the alveoli. It prevents gas exchange. Okay, so if you inflame the alveoli too much, can cause difficulty breathing. That's not good, as we have said. There's over 100 different types of microbes that can cause pneumonia, including bacteria, viruses, fungi, protists, and parasitic worms. Can actually be parasitic worms that invade the lungs and cause pneumonia. The bacteria and viruses are the most common. Now, normally I would go through the different types of bacterial pneumonias and viral pneumonias and talk a little bit about fungal pneumonias. But I'm not going to do that. Viral pneumonias are usually less severe than bacterial pneumonia. Now, there's no cure for viral pneumonia. It's mainly supportive care, just like most other types of viruses. But I just wanted to point that out, that bacterial pneumonia, while you can treat with antibiotics, is usually more severe than viral forms of pneumonia. Pneumonia is the leading cause of death from an infectious agent in the US. Symptoms include fever, cough, difficulty breathing, dyspnea, and tachypnea, which is rapid breathing. Okay, so you would increase your respiration rates because you're not getting as much oxygen diffusing out of the lungs, so you have to breathe faster to try to make up for that and compensate. Okay, now your book goes through 2 different categories of pneumonia. There's typical pneumonia, what we normally think of pneumonia when we think of it, and atypical pneumonia. And atypical pneumonia is what we would say is non-consolidated pneumonia, and typical pneumonia would be consolidated. And I will define that in the next slide here in just a second. But there's some major differences here in fever, low versus high, chills because you're having a fever. They both have shortness of breath. Usually you have a productive cough, chest pain, no chest pain. Let's see, chest x-rays. Well, respiratory distress, I'll kind of let you guys look through that, but the chest x-rays is going to basically be the major difference, and we'll talk about that in a second. But most cases of pneumonia are consolidated or typical versus the atypical. So consolidation is basically when you look on the x-ray, you see white shaded or kind of opaque areas on the x-ray. You're going to see basically the merging of the alveoli sac. So here we have kind of like a cluster of grapes, the normal alveolar sac, and you have the bronchiole coming in. In pneumonia, these will open up and they will what used to be one alveolus is now open up into these huge areas, and it really decreases the surface area for gas exchange, but you can see those cloudy areas on the x-ray. That's what consolidation is. In the atypical pneumonia, that consolidation, that opening up and merging of the alveoli does not happen. Okay, so you're also going to see a lot of fluid accumulation as well. Now, there's a couple ways you can get pneumonia. And you may have heard this term if you've been following the coronavirus about community spread or community acquired or community cases. Those are basically ways that you get an infection from someone or something in your environment. Okay, then healthcare acquired is something we've talked about before, where you get it because of medical intervention. Maybe if you've ever been in the hospital, you've had a surgery or something where you've had to be in the hospital for more than just a few hours. A lot of times the respiratory therapist will come in with a little plastic device, and if we were in class, I would show it to you, where they would make you breathe deeply, right? They want you to use your full lung capacity so that you don't get fluid accumulation and develop a lung infection or pneumonia because you've been sitting around and not using your lungs while you're in the hospital. Okay, and there's other ways that you can get pneumonia from the hospital as well. Okay, so I'm going to skip through all of these slides here. I'll let you guys look at, whoops, not even this, cross that one out. So those are all some of the causes of the typical consolidated pneumonia. I just wanted to give you some examples of the atypical non-consolidated pneumonia. Q fever, tularemia is rabbit fever, if you've ever heard of that. Walking pneumonia. It's caused by Mycoplasma pneumonia. No, I'm sorry, Mycoplasma pneumoniae. That is a less severe form of pneumonia. It's not consolidated. Usually people, they call it walking pneumonia because it's not very severe. You may not even know you have it. And then Legionella would cause like Legionnaire's disease, if you've heard of that before. It's another type of atypical pneumonia. Okay, skip all of these. And then I just wanted to mention fungal pneumonia. That is a thing. You can get fungi into the lungs and causing pneumonia. But mycoses are rare. Okay, remember mycoses means fungal disease. So mycoses, fungal pneumonia is rare, but it can occur. Let's see. And usually fungal diseases are a lot more difficult to treat than, say, bacterial. Okay, so that finishes up our discussion on the respiratory system. Again, we don't have a ton of the diseases that we're going to cover, but I think I gave you some things to think about and work through, and hopefully you'll enjoy looking through the coronavirus activity and the 1918 flu pandemic. Next time we're going to cover chapter 17 and 18, and we'll go from there. So if you have any questions on the assignments, let me know. Otherwise, we will talk to you later.